All right, I'll do the roll call. Commissioner Chow
Present.
and Commissioner Green.
Present.
And I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who were the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples.
Thank you, Mark. You're doing that very well. Let's move on to the approval of the minutes then. So we need a motion for the approval of the minutes.
Move to approve.
And let's see, I guess I'll second so that we can, if there's just two of us, do we need to?
No, if that's all, if there's just two of you, if you second it, Dr. Chow, then that means that it is approved. I mean, I'm sorry, that the motion moves forward. Let me check real quickly to see if there's anyone on the public comment line.
Yes, please.
I don't think that there is, but let me make sure. Actually, folks on the line, if you would like to make public comment on item 2, the approval of the September 28th minutes, please press *3 to raise your hand. No hands, commissioners.
Okay, before we adopt this, let me ask under item 3, under commissioner comments, it then has sort of a dangling commissioner. Are we missing another comment?
Could you tell me the item again, Commissioner?
Yeah, item 3, it's on page 2.
Yes, I see. I will correct that. That's a clerical error on my part, and I will take that out. So
Okay,
if you all, as you vote, if you would vote on the amended minutes, which include taking that out.
Right. I'm wondering if anyone else or any members have any corrections to the minutes that come from our joint conference here before we then adopt it. Okay. I don't see any. So I think since we've moved and seconded, we have adopted the minutes, and we'll go on to the next item, please.
Great. Item 3 is the Regulatory Affairs Report.
Good afternoon, Commissioners. Thank you for giving time on the agenda for the Regulatory Affairs Report. As you can see from the report submitted, we're still anticipating 4 surveys. And actually, I attended a California Hospital Association conference this morning with the California Department of Public Health, and they were very clear that we wouldn't expect any scheduled visits within the next 2 to 3 months, as they're still focusing on their backlog of complaints and facility reported incidents, and they're continuing to focus on COVID related issues. And my understanding from the community is that the laboratory survey from Joint Commission, we shouldn't expect that before Christmas, as we're still running on a 4 to 6 month delay on their surveys. If anything changes, we will of course let the commissioners know. We had a number of completed and closed surveys, the majority of which had no deficiencies. And one was a root cause analysis that we presented to the Joint Commission, and they were very happy with the process and the content of our root cause analysis. And that was around a sexual assault on the psychiatric unit. We haven't received any new plans of correction this month. There still remain a number of open site visits, and I've been working with our regulatory affairs team to put together something a little more graphic as a presentation of the open events, and we'll be able to give you a sample of that next month to see if we can meet your expectations, Commissioner Chow. 5 new reported incidents, 2 HAPIs, a sexual assault, an elopement, and a fall. Of course, OTOP received their accreditation survey in the last month, and there were some opportunities for improvement, but overall it was a very, very successful survey. These were really administrative findings. And then at the end of the report, you can see that our monitoring from our Joint Commission hospital survey is ongoing, and there'll be additional data that we'll present regarding that in next month's report. They were the high points of the report, but I'm open to answer any questions any of the commissioners or the committee has.
So questions or additional comments? And at the same time, let's check the public comment line.
Great. Folks on the line, if you'd like to make public comment on item 3, the regulatory affairs report, please press star 3 to raise your hand so we can recognize you. Star 3. No hands, commissioners.
Thank you for your report. You mentioned that you were bringing something to the attention of the commission from one of the surveys. I wasn't quite clear exactly what it was, Adrian.
I think that it was really just around the completed CARF survey and then the ongoing data from the survey monitoring. I think that's what I meant.
Oh, okay.
And then last month, Dr. Chow, you had asked for us to put something together that was more graphic, that had some graphs, and so the regulatory affairs team began to look at that, and we want to get it right, so we're going to have a draft of something a little bit more graphic to present to you in the November meeting.
Okay, no, thank you. Like I said, some of that was watching Laguna's numbers that seem to work for them, but of course ours might be a little more complicated. So,
as we began to put the data together, there was just a little bit more work to do to make it seamless, so that we the numbers didn't quite match the graphs, and we wanted to get it right. I didn't want to present something to you that was not right, so we just need a little bit more time to get that right. But you'll have something graphic in November.
Sure. Any more comments from any of the members of the committee? Not seeing any. Thank you very much for the report. And I know we have a very extended series of reports here, so which I'm looking forward to. So let's, Mark, shall we go on to the next item, please?
Sure. Item 4 is the fiscal year 2021 Environment of Care annual report draft. And Greg, I've given you permission to share your screen, so hopefully that will work. Okay.
Thank you very much, Mark. Commissioners, thank you very much for having us on today. And I will start with my my slides. Okay, can you see my annual report slide?
Yes.
Fantastic. Commissioners, I don't need to tell you that last year was a challenging year, and this year is not far behind. But with that, we put together the report, and here we go. So an overview, as you know, there are 7 chapters.
Yeah, Greg, you went to, because this is so important, I always find that this really, as a report, tells us so much that's happening in the back of the hospital that we don't see. But you don't really have a full screen, so the slides are coming out a little smaller.
Go to slideshow, Greg, and do start slideshow.
Okay, I'm looking. Oh, I see
At the top
slideshow.
slideshow.
I see slideshow and
From the beginning, or current slide, whatever you want. There
from the beginning. How's that?
That's great.
Okay. Wonderful, thank you.
Fantastic. Thank you.
Okay.
Okay, so we have 7 chapters: emergency management, fire life safety, hazardous material and waste, medical equipment, safety, security, and utilities. The program was deemed effective. Who are the program managers? Emergency management is done by Lan Wilder. Fire life safety is done by myself. Hazardous material and waste management is done by Mike Harris, our former safety officer. Biomedical equipment management was done by Elkin in Biomed. Safety management is done by Mike Harris, our former safety officer. Security management is done by Basil Price, and then I finish things up with utilities management. What are we trying to do here? Well, we identify risks and implement systems that support the hospital environment. We ensure that the hospital staff are trained to identify and act upon environmental risks. We set and prioritize the hospital's EOC goals. Essentially, commissioners, we act as a second set of eyes, whereas the staff is the first set of eyes. We assess whether the goals are being met, and we work to ensure that the hospital is compliant. There are, as with any committee, there are lots and lots of hands, and most of them don't write reports, but yet they are very integral to getting the job done, if you will. And so, as you can see, we get support from Clin Labs and education and training, environmental services, infection control, nursing, quality management, risk management, food and nutrition services, materials management, laundry, linen, messenger services, pharmacy, and then we have some other supporting folks that are with different departments that come along and do EOC rounds with us. So we're going to start off first with emergency management, and that will be Lan Wilder. Lan?
Good afternoon, commissioners. Emergency management, it felt like we've come out of a year that was all COVID all the time to another year that was mostly COVID most of the time. Our overall program objectives were met, and the program was found to be effective. We did pass our Joint Commission survey with excellent overall feedback, no requirements for improvement, and the surveyor actually commented that we are already meeting some of the new standards that he has responsibility for developing with the Joint Commission for improving the whole survey process. We did other exercises, including departmental earthquake preparedness drills for the Great California Shakeout, both last year and just concluded this year's. And we also did a citywide medical surge tabletop exercise. This was primarily for the chief medical officers of each hospital, as well as their teams, to participate in and really look at how we would deal with a massive surge in patients and under quarantine kinds of conditions, isolation requirements and other things. So it was really a good exercise because it was more complex than usual. Our goals and opportunities for improvement during this current fiscal year, we're going to implement a new dashboard of key performance indicators, or KPIs, to ensure more comprehensive quarterly reporting, and also develop and implement updated plans, procedures, and monitoring mechanisms to address the expected updates to those Joint Commission standards. And we're also looking to find additional ways to evaluate and improve our disaster preparedness, emergency response, and patient outcomes in terms of equity. That one is, there aren't any disaster standards for equity. We obviously look at patient outcome and really have used COVID to develop how we look at that and what else we implement to make sure our outreach and other measures are having the effect we need. So that's it for emergency management.
Lan, thank you so much.
Thank you.
The next program up is Fire Life Safety. That is mine. Our program objectives were partially met. We exceeded the goals for false fire alarms. A word on that: why did we exceed these goals? As you may have heard last year and the year before, our current hospital, Building 25, is 100%, not only 100% sprinkled, but it has smoke detection coverage 100% in the building. There is no place you can go in that building without being at or near a smoke detector. Unfortunately, many of our patients smoke, or they vape. And they have the false impression that they can go into a bathroom and smoke or vape, and um, it sets off the smoke detector. We're trying to work with our staff to discourage people and inform them that they shouldn't smoke. Um, we've put up stickers in every single bathroom that says no smoking, no vaping, no, and we've had some limited success, but I think it's just something that we have to continue to work with. The program was effective on overall, and our goals and opportunities for next year is to continue to monitor and manage false fire alarms, to create a safe care experience, and continue monitoring construction projects, which we have quite a number going on our campus, mostly funded by the 2016 bond measure. We also want to continue implementing our fire alarm system upgrade and engage staff and contractors in implementing projects funded by the bond measure. So that is my report for fire life safety. Commissioners, are there any questions?
I think we'll be taking questions at the end, so that unless somebody wants to ask questions at this point. I was thinking we normally get the entire presentation, but since you've asked, I think I saw in the report that the number of false alarms really went down, right?
They did. Commissioners, Dr. Chow, we had, when we were in building 5, I used to have maybe 5 to 10 false alarms a year. And that sets off an unfair parallel between the buildings. There are lots of places you can go in building 5 and smoke and get away with it, whereas you just can't in building 25. So I tried to bring that standard over to building 25, and I failed. I failed hard. We had, I think, 54 false alarms, of which 27 or 25 of them, roughly half, were caused by smoking. It's just something that we have to continue to measure and manage. And it's not an easy thing to do, because fortunately the patients aren't here that terribly long to where you can work with them. So it's just hard. But the overall number did go down.
So we can thank you for the partial event, I think.
I'll take a win where I can get it.
Okay, great.
Okay, the next report up is hazardous.
Actually, I'm sorry to interrupt. I just want to also remind folks that I forwarded questions for Commissioner Green. So please, as you do your presentations, especially, I think there's several for this, not this section, but this whole report, just make sure you're taking a look at that so that you're trying to incorporate responses to her questions. Thanks.
Yes, got it. Thank you very much. So for hazardous material, hazardous waste, this report was put together by Mike Harris, and he was our former safety officer. And he was an industrial hygienist, which that position is also vacant here. So we're missing both an IH and a safety officer here at Zuckerberg. I communicated with Ed Ochi, the DPH safety officer, and asked him what we can do, what strategies he has towards trying to help fill these positions. And I don't know how well you know Ed. For a 50-cent question, you get a $5 answer. And Ed gave me a full page of response. And just to pare it down a little bit, what Ed is trying to do, and he's working with the industrial hygienist positions. There's 3 different classifications: an assistant, the IH, and then a senior IH. And what he's trying to do is revise the minimum qualifications to get more applicants, and then work on a career ladder so that he can move people from the assistant position to the industrial hygienist and then up to the senior position with training and time. He's been working with DPH or with human resources and trying to expedite the hiring authority. And because they modified the minimum qualifications, they got 8 qualified applicants for the positions that we have. They interviewed 5 of them, and 4 of them were offered positions here at DPH. So Ed believes that that's a good strategy, that we can work with people and get them in, work on their qualifications, and hopefully keep them here long term. So that was the strategy that he's using for both the industrial hygienist and the safety officer positions. Moving on to the hazardous material and waste management report, it was partially met. The program was found to be effective. The accomplishments, he continued to work with capital projects and my department, facility services and infection control, to allow construction with operating hospital buildings, which is no easy task, as well as in very close proximity to staff, patients, and visitors. He's also working with materials management and infection control to identify alternate cleaning and disinfection products to address the COVID-related supply shortages. A goal for this coming year would be to conduct an RFP for pharmaceutical waste disposal contract. And that's the reason that we had a partial met, is we weren't able to get that done last year. And he also wants to rebuild the pandemic disaster stockpile that's been seriously depleted, and then reduce and eliminate exposure to hazardous materials on the campus. Moving to the next report would be medical equipment management, and that is with Elkin in Biomed.
Hi, good afternoon. So yes, the project objectives were met. Program was found to be effective. Some of the accomplishments is we hired a biomedical technician with a background in dialysis, which definitely has helped us quite a bit. Since I'm trying to move my technicians to different areas in the department within on campus to oversee, as well as since there's going to be a new dialysis area that will be opening up soon. They're pretty much doubling in size, so this will definitely be a great help. We also discontinued. We got rid of the discontinued bear huggers 750 models and replaced them with new models. Since we currently have an agreement with the manufacturer, and we added an additional 17 bear huggers, which definitely more than one department was very happy. They've been requesting it for quite a bit. During the height of the pandemic, we were able to secure 100 additional infusion pumps. We rented them, of course. Since then, we've returned them, but they were definitely quite a help. On top of that, we also brought back 11 ventilators back into service that were in storage for quite a few years. And just to incorporate one of the questions was, what's the denominator for service request? So I can't say for exactly what the number of devices are used at one time, but I could say, for example, there's one of the graphs that I had was we got a total of 398 infusion pump service requests. We have currently a total of 712 pumps on campus. We also got, for vital signs monitors, 182 service requests in the year. We have a total of 244 monitors. And just to name a couple of others, dialysis machines, we got 181 service requests. We have a total of 23 machines. And for ventilators, we got a total of 115 calls. We have a total of 98. And for the most part, we do have equipment to provide to the departments. We have, Biomed has a storage area where we keep, for example, we keep EKG machines, defibrillators, vital signs machines, but we can't have an additional of every type. If it comes to a point where we don't have a device to give a department and they don't have a backup, we usually work with the manufacturer to secure a loan. Sometimes it's included in the service. Sometimes we just have to issue a PO. And then, yeah, those were answered the 2 questions from Dr. Green. And then as far as goals and opportunities, the goal is definitely to send out more technicians out for training, because this past year we were not able to due to COVID. We definitely want to continue insourcing more of the preventative maintenance repair services, not rely on the manufacturers as much. Definitely that will reduce the total cost of ownership of the device. We would like to hire another FTE with dialysis background. Like I mentioned earlier, we are expanding our dialysis twice as many seats will be. And I think it's about 32. So we definitely need the help in that area. Definitely continue working with clinical departments to develop a medical equipment life cycle plan. Since equipment technology gets antiquated, equipment gets old, it comes to a point where the manufacturer no longer provides support. So it puts us in a really difficult position because if we don't plan ahead and a device breaks down and we're not able to repair it in-house, that means we have to remove from service. And we don't want, of course, the department to be short of a device. So continue planning on that. And of course, bring more new technology, get feedback from clinical staff. Hopefully have more than one vendor that provides the same type of device. That way we're not, the only path to take is one device, one manufacturer. We could get a better pricing overall and perhaps bulk discount. And yeah, that's my report. Thank you.
Commissioners, I might want to add, because Elkin is a humble guy, a high percentage of his equipment are on wheels, which makes it very, very, very difficult to find oftentimes and to service. And that is a real task to keep up with this stuff. So kudos to you, Elkin.
Thank you. Thank you, Greg.
Next one up is safety management. Again, this is another report that was put together by Mike Harris. The program objectives were partially met, and it was primarily because of COVID cases among employees drove standardized injury and illness rate above 8.1. But however, the program was found to be effective. The accomplishments this year, Mike worked with materials management, infection control, and DOC logistics to identify alternate PPE to address the COVID-related supply shortages. He also maintained the injury rate comparable to years that EH&S were fully staffed, despite operating at a 33% staffing shortage for the entire pandemic. And goals that we have for this year is, as I had mentioned, working with DPH, Office of Health and Safety, to fill vacant positions and find more attractive, make the positions more attractive to potential candidates, and hopefully fully staff the department. The next chapter is security management, and with that, I'll ask Basil Price.
Thank you, Greg. Good afternoon, commissioners. With regards to the security report, the program objectives were met and the effectiveness of the program was actually effective. You have listed in the PowerPoint the 7 accomplishments, which includes the approval of 32 FTEs and psychiatric nurses and licensed psych techs to function 24/7 as the behavioral response team. In addition to that, also was approved the enhancing of the role of sheriff's cadets to provide healthcare security services. Go to the next slide. Listed here are the performance metrics, which met and exceeded, except for in customer satisfaction, which we have opportunity for improvement, which we expect through the implementation in this fiscal year of the new staffing model that we can improve with regards to the customer satisfaction. Next slide. Under threats and workplace violence investigations, these are those incidents where it is reported of a threat or act of violence in the workplace, where it is believed that someone's personal safety may be at risk. Part of this process involves doing a security threat assessment to determine the level of risk to the workplace. There was a 5% increase in these investigations compared to the previous year. Threat reports accounted for 65% of these investigations, and 66% of those investigations involved physical violence, which occurred in Building 5. Next slide. Patient on employee reports accounted for 40% of the threats and acts of violence investigations, followed by employee on employee. And then you have on the right a list of the remedial actions that were taken in this year to address the threat and come up with a security plan to protect the victims as well as other staff involved. Next slide. The crimes against persons and property, these are based on crime reports that are taken by the sheriff's office. There was a 42% decrease in reported crime. Battery reports, as you see, accounted for 84% of those crimes against persons, even though there was a decrease in battery reports by 15%, 95% decrease in assault reports. Next slide. Patient against employee reports accounted for 69% of crimes against persons. And then reports from the emergency department actually accounted for 32% of crimes against persons, followed by the psychiatry department. Next slide. Under use of force, there was a 15% decrease in use of force. There's a total of 94 incidents within this fiscal year. Next slide. Of that 94 use of force incidents, there was 473 types of force used, which was primarily physical force being 97%. When you look over to the right, I want to focus here for a minute because a number of Commissioner Green's questions actually came out of the information here in this particular graph, is that you have 35% of use of force incidents involve deputies assisting with patient restraint, followed by 26% of deputies defending staff who have been subject to patient-initiated attacks. So when you look at this chart, those four top categories, defending employees, at-risk patient elopement, patient restraint, assistance, and patients refusing to leave, all four of these categories actually represent that behaviors that initiated sheriff's deputies' response that resulted in use of force that involved patients. There were no incidents that involved victors or visitors or those accompanied patients with regards to use of force. The bottom line, where you have crime response, there are 7 incidents that did not involve patients. These are incidents that occurred on campus or surrounding the campus on the public streets or in non-patient areas such as the Wells Fargo Plaza, where there were use of force. But all other use of force actually occurred in medical settings, clinical settings, outpatient settings, which resulted in use of force. Now, the thing with regards to patient assist and deputies assisting with patient restraint, one of the things that I talked about as we have approved is the BERT team. The BERT team will actually be assigned to the emergency department in all 3 pods 24/7. And so the BERT team, part of their role is to actually assist with patient restraint. And so with the BERT team providing that support and assistance with patient restraint, then that will reduce the amount of time that we need law enforcement intervention to actually address patient care situations. In addition to that, when it comes down to deputies defending staff with regards to attacks, again, you have the BERT team who has the responsibility of rounding within these high-risk areas. And as I mentioned before, they will be 24/7 assigned to all 3 of the treatment areas. Part of their role will be to actually assess and address any contributing factors before they escalate to aggressive behavior. Whether those contributing factors have to do with wait times, crowded waiting rooms, stress levels of the ED staff. The whole primary purpose is to address these issues at the early stage from a preventive approach to prevent high-risk patients from getting to this level where they began to become physically violent, if you will. And then we will start to see with that BERT team to actually begin to reduce not just the patient assist, but also reduce the number of incidents of violent acts by patients with the BERT team. Our measures for the BERT success will actually be to, one, reduce law enforcement intervention in patient care situations, as well as to reduce physical intervention to address risk behavior. I think we have more opportunities if we act in the preventive mode at those early stages to avoid actually getting to a point where it's prone to fighting or some type of physical violence. Let's go to the next slide. When you look at use of force by location and the chart on the left side, 57% of use of force incidents occurred in the emergency department. One of the commissioner's questions was regard to whether COVID was a contributing factor to the reduction of use of force. I believe that COVID actually played some part in that when it comes down to use of force, just based on, I looked at the numbers for 2018 pre-COVID, the amount of use of force in outpatient areas were 15 incidents. When you look at the average during COVID time, the amount of use of force has been 6 incidents for this entire almost 2-year period now. So we did have this decrease as a result of fewer outpatient visits. But on the other hand, you also have pre-COVID use of force in the emergency department was 20 incidents for a year, and in PES was 15 incidents for the year. During COVID, use of force actually doubled. It's 47 incidents in the emergency department, and in PES is 21 incidents. And so you have, even though there's a decrease in use of force, we see an increase in that force in these high-risk areas, primarily based on the number of these incidents actually involve either substance abuse or behavioral health issues. And again, here's another opportunity with the BERT team to actually address these issues, being assigned to do that rounding and providing that support to staff and to these particular high-risk patients 24/7 in the emergency department. I think that another contributing factor for the reduction of use of force in this fiscal year is the fact that the emergency department clinical staff began to start taking ownership and responsibility for the patients by, instead of handing these situations over to law enforcement, they actually have coordinated their own workplace safety committee. In addition to that, they also have a team response protocol to actually address these high-risk behaviors at those early stages, which they've been effective as well. So by them taking ownership and responsibility for their patients instead of turning them over to law enforcement, we again see that contributing to this reduction in law enforcement use of force. And even in those cases where you do have sheriff's deputies have also begun to start instituting verbal de-escalation, using time and distance in order to de-escalate a situation before they actually engage in any type of physical use of force. As a matter of fact, when we talk about use of force by deputies with regards to the at-risk category, majority of these, just based on the fact that they are law enforcement officers, by them physically bringing patients back to the hospital who have eloped, that is considered to be use of force because of the law enforcement capacity, which again, just another reason why we should have clinical staff through the BERT team addressing these issues that involve patients as opposed to law enforcement. Go to the next slide. We break down use of force by race and ethnicity. There's a decrease in every race and ethnicity with regards to force, except for the Asians, which was minimal through the fiscal year. Even though there was a reduction, Black and African Americans are subject to use of force more than the other race and ethnicities. You have on the right the slide with regards to patient-related service calls and use of force. Basically use of force every 10 per 1,000 patient-related service calls, 1 per 1,000 emergency registrations, and then 3 per 1,000 PES, and then 1 per 100 psychiatric admissions. So kind of bring some context to the frequency of use of force with regards to clinical data. Last slide. We started to break down use of force by acts. 42% of use of force is in response to fighting. When we speak of fighting, in most cases, it's patients actually resisting treatment. And in some cases, as I mentioned before, they're leaving and they're either under 5150 or what we consider to be at risk, and then having law enforcement return them back would be categorized as use of force as well. Patient-initiated physical attacks by race and ethnicity, 41% of Black African Americans in this fiscal year were prone to physical attacks than other race ethnicity, followed by whites at 32%. So that concludes the security management report. I'll turn it back over to Greg.
Thank you, Basil. Commissioners, the last report is my report, Utility Systems Management. It was met. The program was found to be effective. Goals and opportunities for improvement coming up are continue to support the chiller replacement project in Building 2. Those chillers, one being 47 years old and the other one being 15 years old, serve Building 5. The next project that we're going to be working on is cooling tower replacement because the cooling tower was put in 1975, 1976. So it's reached its life expectancy. And then the final thing is that we're going to further develop, with the assistance of the project management team, the replacement project of our electrical switchgear in Building 5. And we have been meeting regularly to work on that. Commissioners, that is the Environment of Care report for this year. Before I ask for your approval, do you have any questions?
I think let's see if we have any public comment. And then
Sure. Folks on the thanks, Dr. Shaw. Folks on the line, if you'd like to make comment on item 4, please press *3 to raise your hand so you can be acknowledged. Again, *3. And I don't see any hands. Let me make sure. No hands, commissioners.
Okay, good. Thank you. Commissioner Green, any further questions? This is a very extensive and very complete report.
Yes, well, thank you so much. This is exhaustive work and exhausting probably too. And I think it's remarkable what you've been able to accomplish all during, COVID as a backdrop to all of this. And I really appreciated the longer report, which really is full of data. I had a few very, minor questions, and they're on different sections of your report. One, I was still curious about two things: shortages of equipment as well as the turnaround time. As you quoted the ratios of number of calls per type of equipment, it seemed like it was like 1 to 3 in some instances, and obviously it's spread out over time. But do you have any challenges? Maybe I'll just talk about all the questions and then you can answer. Do you have any challenges being able to replace vital equipment? I mean, EKG machines and so forth are one thing, but the ventilators, the vital sign monitors, and especially the infusion pumps, which we have tremendous problems with as well. You know, when patients need it, is there any issue? Are you tracking time from a call to the time you're able to answer the call, especially at night and weekend? So that was one thing. And then on the safety, I really appreciate the parameters you've set forth to assess the value of the BERT team. One thing you mentioned as part of the verbal report was that the rates of use of force in the emergency room were up as the rates in other places may have been quieted down with COVID. And I'm wondering the extent to which the fact that PES patients need to stop in the ED, I know that that's not a huge volume, whether that colors some of the numbers, maybe I misheard you, but if that colors some of the numbers that are currently reflected in the ED as opposed to other sites. And I mean, those were the you know, the two things that I learned new from your very excellent explanation of the reports.
So as far as medical equipment, I would say our biggest challenge right now is ultrasounds, especially those located in building 5, building 80, building 90. You know, just trying to get funding for that, because a lot of the ultrasounds there are already antiquated technology, and it's come to the point where they're no longer supported by the manufacturer. So what I try to do as the biomed manager, we try to repair them in-house if we can. Some of our technicians are trained in general ultrasounds, but not specific models. Another path we'd like to take, if we can't go through the manufacturer, is sending out to a third-party vendor. Sometimes they do provide support, sometimes they don't. It all depends on if there's parts available, and sometimes they get the parts directly from the manufacturer. So if a device is, you know, it's been out on the market over 7 years, as the time goes by, it's going to be less likely we'll be able to get parts. So that's been the biggest challenge as far as equipment right now. Ultrasounds, like you mentioned, we have a well over 700 infusion pumps, so there's no issues there. There was definitely an issue at the height of the pandemic. That's why we had to rent an additional 100 pumps. And then, you know, for beyond that, I asked, you know, between the ED and ICU who used the majority of the pumps to talk to each other, because sometimes some departments have a tendency to store pumps, you know, because of course they don't want them to be walk away, or they don't want to call central distribution. So that communication has improved. So I'm glad for that. Outside of that, ventilators, we were lucky enough to have funding to purchase an additional 25 vents recently. So that's great, because the ones that we currently have, they're the manufacturer's Draeger and the old models of Vita XL, those are going to be extinguished at the end of the year. They're no longer going to be supported. So we bought an additional, the model is a V500. So that's helped us. And I know RT is still working to acquire more vents because they're needed. Other than that, I would say ultrasounds are definitely our number one, especially when it comes to probes, especially in the ED, you know, because of the type of patients that we take care of. A lot of times we have end user damage. So turnaround time sometimes could be quick depending on what the issue is. But we've run into some situations. But the good thing is the ED, we have over 7 ultrasounds. So, and we currently have them under warranty. That was something that I initiated last year. So we have a 2-year coverage for that, which is great because we can get loaners. And by the time they repair them, we'll get a loaner within, I would say, 2 business days, which helps us quite a bit.
Great. Well, I can certainly understand that problem. We have it too on the ultrasound.
And then to answer your other question regarding tracking, so we necessarily, our database is not set up to indicate how long it takes from the time we get a service ticket to the time it closes. But every 2 weeks, I do have a meeting with my team where we discuss older work orders. You know, I definitely try to communicate with my technicians to make sure they add their notes there. Tell a story. You know, what was the issue? What's going to be the resolution? Who did you contact within the department? That way, if that technician's on vacation or out sick, I could take the lead or somebody else can. So, and we, you know, every 2 weeks, we definitely try to make sure we close out work orders and figure out what's the issue. And if there's something that I could step in and either I could make the call directly to the manufacturer or call a sales rep to get a loaner, then that's what I have to do. I'll do, just to make sure we have the right equipment out there, enough of the type of the right equipment to make sure we're able to take care of our patients.
Thank you very much.
You're welcome.
So with regards to the use of force and the increase in numbers with PES and emergency department, is definitely the fact that you have PES patients first stopping at emergency department before they're transported over to the PES. That's definitely a contributing factor. Just based on the fact that we've seen those numbers with use of force increase, actually double pre-COVID in that particular location. And then when we start looking at diagnosis, the majority of use of force is based primarily on behavioral health and substance abuse. But again, I think adding that BERT team is going to help us because a lot of the support that deputies are providing to clinical staff is patient restraint. Well, that's more of a clinical role. And so having the BERT team who will have that role and responsibility will actually, one, provide the service, but we will eliminate the law enforcement intervention, which will reduce further those use of force numbers.
When do you think you'll have some data on the BERT team success? Because you got great metrics developed. When do you think you'll have any meaningful data on the metrics?
Well, the BERT team is managed with Terry D'Antoni. She can speak to this as well. They actually have identified a BERT manager who's currently gathering data with the existing BERT team, which is the existing staff within psychiatry. As we implement this program in March, that's when we actually will start gathering the data to measure the effectiveness of this new staffing model, which again, implementation will be in March 22.
So maybe third quarter, end of third quarter. Okay, great. That I will really look forward to hearing that. I bet it's going to be great news.
And
Sure.
Dr. Green, this is Terry, that we also look at the data now that's going on. We have LPTs in our emergency department. They help with de-escalating patients. We've also seen a really nice trend down of our activations, as Director Price has shown you, with utilizing the BERT team as pre-rounding, just as we would on clinical patients that have clinical needs. We've also expanded to do some of the outside clinics as well, just as a pilot, a test of concept, and we have seen some success. So Joan, who is our nurse that's working on all our data, will have some metrics to show you, and hopefully they will prove exactly what we think will happen.
Yeah, great. Well, I'll look forward to it. Thanks so much.
Thank you. And in fact, you've answered just about all my questions on the BERT team. And I want to thank Director Price for continuing to work on the problems of not only security, but safety, and trying to find the right mix of people and intervention for the patients as we've been reviewing this for at least several years. I'm wondering though, and I appreciate Terry's comments too, who is going to be producing the BERT report? And it should be in conjunction, of course, with security to be able to, bring together the data. It's sort of like what we're seeing on the street outreach teams, where we're able to see that it in fact, if something falls in numbers, that we're over here, we've achieved these things, right? Or in this case, we're looking for potentially less law enforcement involvement and a lot more involvement with a positive result for our patients through the BERT team, right? So is this going to be a joint effort, I would hope, on the part of both of you?
Yeah, most definitely, and I'll let Terry speak to this as well. But as we implement BERT, BERT is performing both a safety and security function. So that data and that reporting would fall up under the security report. However, I foresee me jointly reporting that information out with the BERT manager who is dealing with this hands-on day-to-day. But I'd like to hear Terry expound on that as well as how she sees that reporting as we move forward.
Yeah, thank you, Basil. So currently, Basil and I meet monthly and we look at all the data together of what we have preliminarily, and that's how he came to some of the areas he has of where we're going to have the BERT team. We are currently looking at the data together. We are looking at it from two different perspectives. One is clinical data, people that have behavioral issues due to psychiatric illness, is it a TBI or what have you. So we're looking at it there and collecting data. So how can we best interact with different types of patients? And then there's those with just purely behavioral problems that come in that if someone, if they have psychiatric illness and they have a behavior that associates with it and that they're going to become assaultive, those kind of things we talk about together. So we look at the data together and we tease out what's going to help us to clinically help the BERT team manage patients and those that are going to have taken away potential assaults and things. So we will be combining it. I think we have a schematic. I don't know if we have a final version of it yet, but we're looking at current data to project future data.
Very good. Well, I think this will be really an exciting report and another one that shows a real change in culture, and I think can also be helpful for the rest of the country to understand. I mean, we're having this big discussion, right, nationally about presumed use of force, and yet we have to have some security and at the same time. So I appreciate that, and I'm looking forward. I think we all are looking forward to that type of report. Maybe even a preliminary as to what you were all thinking would be really nice. I'm wondering if Director Price has any comments, though. Also, it would appear that with the more secure building and lesser entrances, we've also achieved some safety as COVID becomes more an endemic and becomes more a regular type of, a disorder that we have to handle, and unfortunately a new infectious disorder. What do you see, and what have you been working with the administration in terms of campus access?
That's a very good question, Commissioner. Actually, just talking about that this morning in the security meeting, that, on an annual basis, we do a security risk assessment. One of the areas where we have opportunity to strengthen our security with regards to access is not necessarily the buildings. We've done a lot of work with incorporating electronic security to control access to floors as well as to the exterior buildings. Our biggest opportunity now is the outer perimeter. The fact that we have this 24 acres that is accessible 24/7 from 4-block radius or with number of entry points. And so we're looking at that piece of the access control. In addition to that, we're also working with the city attorney's office on developing DPH-wide policies that address private and public spaces, so that we have that in place, that DPH, although these are public buildings, you do have to have business here. And so that also is another measure, another thing that we're doing to actually address the whole security piece. But I think right now, our biggest issue is the exterior perimeter and the 24/7 access to the facility grounds.
Thank you. Those are very helpful comments. Looking through the very extensive and once again, a very comprehensive report, I had two other questions. One is sort of one that comes from the past, which is the elevators. And wonder if somebody could address that. We're still having elevator failures. I thought that we were putting in new elevators in building 5, but maybe they're not all new. So
Dr. Chow, so I can address that. We still have elevator failures. I believe our report this year. It's down a little bit from last year on elevator failures. To be clear, I consider a failure is an elevator out of service for 4 hours or more, or an elevator where we had a passenger trapped. And so from time to time, I'd say about once a month, maybe sometimes 2 or 3 a quarter, we have entrapments. And then as far as elevators being down or elevators failed, we've had problem with some of our older elevators on campus that are in patient care areas. And for instance, I think in my mind, building 80, building 90, some of those elevators are pretty old, and they are really due for upgrades. And it's a budget item. We received a quote from our elevator company to upgrade all of the older elevators. It was somewhere in the $4.5 million price line to do that. Worked out to be about I believe it was about $500,000 per car, which is steep. And so that doesn't mean we can get that all done at once. That tells me we have to phase this in over a series of years so that we could spread out the pain, if you will, and seek the funding on it. We also, there are certain elevators that are just really problematic, and two of the most critical elevators on this campus are not open to the public. They are the cargo elevators in Building 5. All of our food, all of our equipment, everything comes through those 2 elevators. And unfortunately, they get hit a lot with pallet jacks. And it's just very, very difficult to maintain them. We do a lot of repair work on them. And so they are, if you were to see the full report, you would find that elevator 19 and elevator 20 in Building 5 are down quite a bit. And it's primarily because they get hit with pallet jacks. Fortunately, we haven't had too many outages where they were both out for more than an hour or two, but it's a problematic series of events.
Understand they're old elevators, so the ones in our new building are doing fine.
They are doing much better. We had initially some problems with the new elevator cars, and there was a service mod by the manufacturer that came through and did a lot of repair work on them to bring them up to a better modification, if you will. And we've had fewer problems in Building 25 as a result of that.
Thank you. Lastly, I recognize that you've added a chapter in regards to the other departments who, as you call, were unsung heroes, and that was very nice.
Yes.
To show the interrelationships. So my concern as to how we were going to address it is under the challenges in infection control, where they are talking about multiple competing high priority issues, or you've written this, in relationship to making it difficult for the department to establish stable partnerships with various departments. So I'm not sure, of course, this is a department not in the environment of care administration, but if it's sitting there and these are challenges, who or what, or perhaps administration is working on trying to overcome those that are in this document. It's on page 47 out of 48.
Hi, Dr. Chow. I can speak to that partially. Infection control reports up to quality management. During the period for most of this report, we had vacancies in that department. We have hired 1 additional full-time infection prevention control nurse, and we had one of our infection and prevention control nurses who was out on medical leave come back and work and be back at work for some time. So some of those challenges were around staffing, and they're particularly hard positions to hire into. It's a very, very specialized skill set. So we strategically hired someone who was certified in infection control, and she joined the team a few months ago, and I know that she's making a big difference in the workload. So if we were to look at that department's workload today compared to when Greg reflected upon his report, I think we'd see a different picture.
Good. Okay, so
Thank
we're
you, AJ.
working on it and trying to draw that together, because that would look like a vital element for our overall safety. Did anyone have any other comments, or were prepared for a motion to move this report with acceptance to the commission? So no further comments. We need a motion. As I understand, it says that we're to consider approval. So is there a motion for approval, and we will then submit it to the commission?
Move to approve.
Okay, and I would second it, and I think Mark says that that's it, and we don't have to vote. Is that right?
Yes, sir.
Commissioners, thank you very much.
Well, I think we thank you. This, like I said, is always extraordinary. Commissioner Green have both been in many hospitals. I'm sure that at least I have not seen such complete reports on, shall we call it, the back office. It is so important. I mean, we have a lot of frontline people who do get appropriately thanked, and we just don't have enough effort to thank the people who keep everything going. And I again commend the department to having again provided really an excellent report. So thank you all. With that, then I think we'll go on to our next item, please.
Sure.
Thank
Item
you.
5. Thanks again, everyone. Item 5 is the fiscal year 2021 Zsfg annual report draft.
Good afternoon, commissioners. It's very nice to be with you here this afternoon. And I would just like to pile on with the congratulations for the Environment of Care team. I mean, they are really the back of the back office team. And, you have a portion of their work reflected here in this really expansive report. But I mean, between Greg and Basil and Lan and Elkin, they just, and Mike when he was here, they just do an amazing job, and they're always available for us no matter what the task. I mean, for example, this past weekend when we had that, atmospheric river, we have our tent city that needed to be addressed, and they were, really available for that. I could go on and on. It's remarkable the work they do, and they really they do it without complaint, and it's I'm very grateful to them for that. So thank you for applauding them. Now I'm here to talk about our annual report. This is the 2021 annual report. It's a really great opportunity for us to tell our expansive story from last year. As you know, this is the time when you get to view it here in the JCC, and then we review it more thoroughly and completely in a final form, along with your commendations of team members at the full Health Commission meeting on the 16th. I want to extend an effusive thanks to Casey Anaya and Kim Nguyen for putting this report together. They actually start making this report as soon as the old one is done. And they work on it assiduously throughout the year, and they review it and change it and upgrade it, and it's really because of the two of them that you see this fine product before you today. So thank you to Kim and Casey. The report is designed for many audiences and purposes. It's a yearbook. It's a really handy guide for statistics. It helps us celebrate teams. And so that's something to keep in mind when you go through it, is that it's a document that's designed for many audiences. What I wanted to do is just run you through the organization and then invite your comments and edits. So first of all, we start with my welcome letter and a high-level overview of the organization, including the mission, vision, and values. One part that I find really useful throughout the year is the Zsfg by the numbers, both the very high level numbers that you see right after the table of contents, and then some more detail about statistics and the finances. We follow this year, this is, I think, a new way of organizing this, with our very key partnerships, both with UCSF and the foundation, and give specific examples of why those partnerships are so critical and special to us. Then comes COVID. Of course, the last 2 years, our reports have been replete with lots of information about COVID. And then we go into other highlights from the year, including the many surveys that we had and in which we excelled, fortunately. The next section has to do with our building projects. Really, there's just building all around us at this point, and will be for the next probably 4 to 5 years. And then our True North. Of course, as you know, you hear about our True North or some aspect of it every single meeting. I'm very proud of the fact that we were actually able to sneak in a Hoshin about a year ago. And that was very deliberate on the part of our executive team to try to center and drive our work very much along our True North strategies, as COVID was, was all around us during that time and still is. So then you get to see our True North, our work and the metrics around that. A whole section on staff celebrations, the patient love letters, which is a small sampling of many that we receive here, and then finishing with descriptions of you all on the JCC and the executive team. So again, I'll present this, in more detail with a proper PowerPoint at your second Health Commission meeting in November. But at this point, given your real in-depth knowledge of what we've done all year and what we do, in general, I would love to hear your feedback, comments, questions about any aspect of the report.
Thank you. Is there any public comment, Mark?
Folks on the line, if you'd like to make comment on item 5, please press *3 to raise your hand so we can acknowledge you. *3. I see no hands, commissioners.
Thank you. I've had the opportunity to work on the document for many years with the staff, and this is really one of those outstanding ones, I thought, which, as Dr. Olick said, encompasses not only a history of what occurred this year, which was, of course, monumental and historical, but is used as a fact booklet for people who are interested and also we would like to become interested in the general. So it accomplishes many things. So I had only one comment back on the page 31 as I was rereading this, that I realized that we've identified the places of many of the building projects, except the seismic retrofit is not. It is one I think that we might want to at least identify that. I believe that it's actually on building 5, right?
Yes. Yes. Building 25 came with a seismic retrofit.
Right. Yeah, that's what I was hoping.
All those base isolators that you walk over when you come on campus.
So I think we just put back in building 5 on that. You know that we talked about that earlier in terms of some of the others, and they really all work. And I had, at least personally, really an appreciation of all the work that has gone into this book. Now I consider it not a book, but a booklet. Okay. And I think fulfills what we used to have. I think there were people who felt that we should highlight patients and how patients actually benefit from our institution, and others who felt that we needed to be more data-driven and data-oriented. And I think this sort of combines the entire thing along with, as you say, a yearbook for a very important year. So I'm hoping the public will really appreciate it. I certainly hope our commission does. And I'm going to ask Commissioner Green her comments.
Well, I mean, I think this is fantastic. And as I looked at this, I feel so honored to have even the smallest participation in this amazing institution, all you've done. I mean, I think this is the perfect combination of head and heart. And I was looking at our little circles. Turns this way kind of is a heart. So it's like data and motion all in one. I love the pictures. It brings the institution to life in such a profound way. And it really shows the breadth of the programs and the structure. Never mind all the amazing work that has been done in conjunction with the pandemic. So I just love this. The only question I had, because I think it may come up at the commission, is the gender information on page 8. That are we going to include any Zsfg data in that section?
Yeah, that's a great question. I know we had a discussion about that, and I'm going to ask Kim maybe to address that because she's closer to this than I am, because I don't remember the details of that discussion. I
Hi,
think
this is Kim.
Thank you.
Yeah, we're gonna work with the team on that, and so it's just gonna take some more time to collect that information. But let me check with the team, and then Susan, I can share further information with you, and then we can get back with commissioners via email.
Yeah.
Great.
Yeah, I mean, as you know, as part of our True North work, we, we've worked really hard on getting accurate, real, and Zsfg data. And I know we've been more successful on the real side than the Zsfg side, and so that may be part of what the issue is. But we will definitely look into that before it comes to the Health Commission, as well as the comment that you made on page 31. Thank you, Dr. Chow, for your review. I know we spoke about that before, and we'll fix that and make it clear that the seismic retrofit is in building 5. I just want to say how much I appreciate both your support. This is shockingly, it's kind of a small snapshot of all of the amazing things that go on here, and you all know that and support us, and for that we're really grateful. So thank you very much.
I agreed with Dr. Green that after you read this, you really feel proud that we can be a little part of it, and I think we're all very grateful for the work that you're all doing here. I know you keep hearing that all the time, but I think after reading this again, it kind of comes out, and seeing the rest of the documents coming, that it's just amazing the work that you do in depth that really shows that I think the organization cares very much about how they are delivering care, and we all do appreciate that. So thank you. I know you're going to deal with the financials also as a footnote, but if we have no other comments, I think on this one, then we would consider. Mark, it says that we're considering for approval. That's for us to recommend moving it to the commission?
Yes, it's all of these items 4, 5, and 6 are all just really recommending that the full Health Commission approve them at the November 16th meeting.
Oh, right. Okay, so I need a motion for that.
So moved.
And a second, and so therefore we're very proud to move this to our commission. So thank you very much.
Thank you both. And I also want to take this opportunity to thank the executive team, who are almost all of them here, because they're the ones who have really led the work. So, I'm so proud to be a part of the team with them. And I just want to make sure that you recognize all of them as well. Thanks.
Thank you. And we'll give the same public recognition, I think, to everybody at the commission. Thank you.
And before we move on to the next item, I just want to also just throw out there to Kim and all of you, when you have, if you're not able to collect the data or find the data on the transgender folks, you can put a footnote. I mean, that's kind of what the commission has asked for, to say that this, and to hopefully have a promise that next year's report will have more data. I also noticed that there's a 0% Native American patients from last year and this year, and we're doing a health equity resolution on that population. And again, if there actually have been like 5 people and it doesn't show up because the numbers are too high, you could also put a footnote saying for smaller populations, you know, sometimes it turns out 0. That way it recognizes that those folks exist. And we're trying to honor that the communities that have smaller populations aren't invisible in our reports. So just a thought.
Great. Yeah, thank you so much for mentioning that, Mark. We'll take note.
Item
I
6
do
is
appreciate that, Mark. I appreciate that you actually have helped bring some of the points that our commission would like in the report. So again, I want to thank you for also for.
Oh, sure. We're a team, right? We all work together. Item 6 is 8.09 provision of care policy.
Good afternoon, Commissioners. I'm here to present the policy on provision of patient care. The policy remains the same, with the exception of updating strategic goals and data sets to reflect the fiscal year 21. This data also aligns with the annual report that was just reviewed with you. That's it. Waiting for approval.
Yes. Because we didn't get a red line copy, I got to read the entire thing. And once again, it's just amazing all the work that we're doing here on our campus. So thank you. And Commissioner Green, any comments or else well, let's first find out if the public has any comments.
Sure. And Commissioner, I did forward you yesterday a red line copy via email of the policy, I believe. It wasn't included in the packet, but it was emailed. So for the I think for the full commission, they'll have a red line version.
Okay, yeah, I think it'd be easier for them, but I mean, it was an opportunity to read it again, and again in conjunction also with the annual report. It's just, you know, it just brought everything together.
Folks on the line, if you'd like to make comment on item 6, please press *3. Item 6. No hands, commissioners.
Okay, Commissioner Green?
Yeah, I think I've asked this before and I apologize for not remembering the answer, but where do we put Medi-Medis in the data mix? I know it's not a big percentage of patients, but I wondered how you categorize them as Medi-Cal or Medicare, because a lot of them are disabled even if they're under 65, so they're on Medicare.
I'd have to find that information out for you. I don't know offhand, but I can certainly get it for you.
I would be curious just because the benefits and such are a little bit better for patients if they're Medi-Medi, and I'm just curious.
Yeah, Commissioner Green, I looked into that question because I think you had it regarding the clinical documentation integrity report. So about 30% of our patients here have Medicare. I actually don't know exactly what percentage is are dual eligible, but it is substantially smaller. But what we heard from our folks in health information management is that for most purposes, people are categorized based on their primary payer. And for many of our Medi-Medi patients, it's actually Medi-Cal. So a lot of those folks will be in the Medi-Cal group. I'm not sure that that's the case, though, across the board for all circumstances.
Well, thank you. I appreciate that.
So it sounds like, and maybe Dr. Winston, you can sort of double check this, because in Medicare is normally the payer in the inpatient, then that sounds like it's probably put into that category. And for much of outpatient that may not meet Medicare requirements, then Medi-Cal takes over a lot of those services. But I think it's in the outpatient that I think that would be a very interesting question, because Medicare under Part B does cover outpatient. So I'm not sure. I think I'd like to ask the question, especially on the outpatient side. You know, is the prime insurer under us here really Medicare or Medi-Cal in that group?
So Dr. Chow, unless Jennifer can tell us the answer to this right away, because you're exactly right, Medicare would pay on inpatient and Medi-Cal on outpatient, I believe. Let us research this and get back to you after the meeting. I just want to be sure that we're responding correctly, because we'd want to check that for the annual report as well.
Sure. Very good. I think a very good point. When we have the Medicaid patients, at least we would understand what category they are in.
Yeah.
For which
Thank you
service.
for raising that.
Okay. If we have no other questions, we can then move the provision of care recommendation to the commission.
Move to approve.
All right, and I would second that, and we therefore will move it to the commission for acceptance, and we can go on to the next items, please.
Thank you. Okay.
Thank you.
Thanks, Terry. Item
Thank you,
7
Commissioners.
is the is 17.01 Performance Improvement and Patient Safety Program, the PIPS policy.
Hello again, Commissioners, and thank you for reviewing this policy. So I do believe that you did eventually get a red line, but I appreciate you may not have had a chance to review that. So I really wanted to just summarize the changes. The policy overall remains very similar to the year before. Our big focus this year was really on equity and diversity. So we strengthened the language throughout the policy around equity and diversity, both for our patients and our staff, and the way that we deliver care. And we specifically in the PIPS committee section, we strengthened the language there to describe how the PIPS committee drives those who report to the PIPS committee. And embed equity into their quality and safety work. And this gives me an opportunity to really give credit where credit's due. And Leslie Safier, who's not here today, who's our performance improvement director, she meets with every group, clinical and non-clinical group, who present at PIPS on a monthly basis. And she asks and guides them through their report, and she asks them questions. She asks them questions about where their report aligns with True North, but she always has each group focus on what their diversity metrics are, if they're developing them, and pushes teams to usually when a team begins to report out on diversity, it's around they kind of look at their data and stratify their data on race, ethnicity, gender, and those kinds of things. And that's really the starting point for most teams. We then encourage teams to take that step forward and not only measure, but begin to address change and analyze the data, see if there is inequities and how that can be addressed. And I really want to, since I've been in this position as Chief Quality Officer for a little over 6 months now, I've sat in on many of these sessions, these pre-PIP sessions, and it's really, that work begins there as we talk about these reports. Other than that, the other changes in the report are grammatical or strengthening the links within it to our True North. So I just want to give you a chance to ask me any questions about the policy.
Mark, let's find out if there's any public comment.
Sure. Folks in line, if you'd like to make comment on item 7, please press *3 to raise your hand. *3. I see no hands.
All right. Good. Well, let me just ask more question on, you had submitted to us also the National Patient Safety Goals, and where exactly does this fit into the annual plan? And then what these scoring boxes mean? There's an R, and then sometimes there's a D with a circle.
Okay, so so the National Patient Safety Goals sit within the work that quality management does, and is disseminated out to the floors as part of the rounding that the patient safety nurses here do, and it really is linked very closely to the patient safety plan. For those letters at the side. Let me just grab it on paper. I want to make sure that I'm answering. So there are, against those standards, the Joint Commission's nomenclature around the risk to patients regarding these standards. Some are high risk, some have R's, some are not. Because these are the National Patient Safety Goals, they nearly all have that R against it. And then the D is if documentation is required to demonstrate our compliance with that standard. So when the Joint Commission asks for documentation, it means a specific policy, plan, standard work, or it being embedded into something like our PIPS policy to demonstrate that that's how we meet that standard.
Thank you. It's very, very extensive. And I guess all the Joint Commission chapters kind of look like this.
They do, and you know, like I say, the National Patient Safety Goals are the Joint Commission's comment on the national trends in risk to patient safety. And I have been asked in my career why they don't change very much over time, and that's because healthcare generally, not Zsfg, not the West Coast, but nationally and indeed internationally, these things, we're not fixing them. We continue to see them as issues in healthcare across the nation and internationally, which is why the Joint Commission choose to focus on them and assess our compliance with them specifically at survey time. And then if you were to look at the broader Joint Commission standards manual, not all standards have a risk against them, but they're still important. And they could be linked to reimbursement, they could be linked to accuracy of results, they could be linked to underpinning themes, standards, and regulations that are assessed as part of the Joint Commission survey process.
Okay, yes, it's become much more extensive than when I was doing surveys with them back about 30 years ago. So I feel the pain for you in trying to meet these standards, but of course there are basically good reasons that much of this is in place. So it makes our hospitals all safer and our patients safer. So.
I'm a little bit of a nerd and I like the standards. I actually like getting the standards out and figuring out which standard applies to what we do in the hospital. And I'm a little bit of a nerd in that respect.
Okay, well, very good. I'm glad I'm not a surveyor anymore. Commissioner Green, any questions?
No, I mean, this just shows you the amount of work that is required to do these, and I appreciate the explanation because I was kind of scratching my head on R&D as well when I looked at this. And now I'm just so glad we have a world-class nerd at the helm here.
Well, it's
Thank you.
I get to show so much work in order to run a hospital and a health facility. It's just amazing as we see it all come together for this annual meeting. So we need to also submit this one. Did I ask for public comment already, Mark?
Yes, sir.
Oh, okay. So we can now ask for a motion to move this to the commission with our approval.
Move to approve.
And I second that, and therefore this will go forward to the commission. Okay.
Thank you, commissioners.
Thank you very much.
Item 8 is the Zsfg Chief Executive Officer's report and emergency department update.
Okay, good afternoon. It's me again. I just wanted to call out a couple of things. So the first section has evolved into, what's the latest that's going on related to COVID. And I wanted to call out a couple of things here. One is that the vaccine mandate, has been has been somewhat of a challenge to navigate in DPH. I think, in general, we have done well, and it has done what it was intended to do, which was encourage people to get vaccinated. But a little known piece of this was a really unprecedented collaborative partnership that we were able to be in with SEIU Local 21. A couple of the members there were very interested in advocating with their membership to get vaccinated. And so so we planned basically a big forum for the members, and the forum included the leadership of SEIU, Local 21, me. They invited Dr. Andre Campbell to speak to the membership, and it was a wonderful opportunity to work together to encourage folks to get vaccinated. And I don't know how many people got vaccinated as a result of that forum, but I really appreciated that the union leadership reached out to us and wanted us to participate with them in this effort. So that's one piece here. The other thing is that we talked about boosters, and of course there's new news today with respect to boosters. We're able to give booster shots now to folks who were initially vaccinated with Moderna and J&J. And there's guidance that has already started coming out in the department. Dr. Luke Day, of course, leads that effort for us, and we will start doing that. The next time we talk, I'm sure we'll be talking about initial vaccinations for kids aged 5 to 11, which we expect to get more specific guidance about and starting to do next week. So that's the big news for us with respect to COVID. I think there's a lot of other information here. I think I'll dispense on the narrative piece unless you have questions about that, and I'll move into the data.
That's fine. Why don't we move to the data?
Okay. So starting, well, you can see on page 8, you can see the journey we've been through with COVID. Cases are coming down around the city, and we've had a little bit of up and down here in the past few days. We have 11 patients in the hospital today, which was a slight increase from before, but generally the numbers have been coming down. In the emergency department, our volume is low, admissions are low, and that's really because I think by and large we've been on ambulance diversion a very unusually high percentage of the time. And the root cause for that, for the most part, is staffing. And we spoke about this the last time we were together. Like every hospital in the United States, we've experienced some pretty significant staffing challenges for a variety of pandemic-related reasons. Fortunately, and you'll hear more about this in the HR report, we are coming out of that, the depths of the staffing challenges we've been having. But I think the department that's been hit the hardest is the emergency department, and that's what leads to these data that you're seeing here. I hope that over the next month, and by the time we speak to you again next, that we'll see those diversion numbers coming down and the numbers of the volume in the ED starting to come up, because we'll be able to handle more patients. Bright spot here is on page 11. You'll see the transfers from the urgent care to the ED are going up. So the urgent care is really helping us with the volumes that we have coming into the ED. So that's been helpful. The PES encounters are down. You can see in the admissions. Well, let me just speak to the PES encounters. I think the PES encounters being lower than they have been is also a result of ambulance diversion, because we're seeing more patients, including those with who might have otherwise come to PES, go to other hospitals. So we should see that change along with the other, when staffing comes up in the ED, we have less diversion. We should see these numbers go up as well. I think the bright spot that we're seeing in the daily admissions, we're starting to see some movement with our psychiatric lower level of care patients, which is outstanding. I think these are early signs of new resources being available through the new beds and facilities work that is happening because of mental health SF. So that's been really nice to see that we have more capacity in our inpatient psych unit. I think I will stop there. I know you probably have more questions about the data, but I'm happy to stop and let you ask them about things that you are most interested in.
Okay, Mark, shall we see if there's any public comment?
Sure. Folks on the line, if you'd like to make comment on item 8, please press *3 to raise your hand. *3. No hands, commissioners.
Thank you. So I'll just start with the one thing that I saw, and thank you for the discussion on the diversion. It also shows that you have a larger number of people leaving without being seen. Is that some sort of related to weight or?
Yeah, I think it's all related to the staffing issue. When we have fewer staff, it's harder to get to them as soon as we'd like to, and that leads to higher numbers of leave without being seen. So again, this is really something that we are not happy with, and we want to correct. And we are in the process of it getting corrected. We have staff coming out of training programs in the ED. We have registry staff coming in. We also are having staff coming in med-surg, which is the other area that's been hit really hard with staffing issues. So again, you know, this is not great. It's not where we want to be, and I expect that our partnership with HR and our hard work in this area is we're going to see a change over the next month.
Thank you. Commissioner Green, any questions before I ask my next one?
Yeah, well, thank you for the report. My main question was about diversion, and it's certainly explicable. And I was delighted when I saw what's going on in the next report with vacancy and the efforts that have been made. So, yeah, it's a huge problem everywhere, and we're really suffering as well.
So do we think, and I know that's in the next report, but Dr. Ehrlich, that what the next report shows is that we would then have more capacity in this coming, I mean, what's your anticipation on the coming month?
Yeah, as we start bringing in staff, to the emergency department, that means that we can accommodate more patients. So we'll be on diversion less of the time, a smaller percentage of the time. It will also help having more staff in the med-surg area in particular, because then we can accommodate more patients being admitted to med-surg. You know, now we're very limited, and we've actually, not only have we not been able to open our surge unit, H58, when we might have otherwise done so because of the numbers boarding, both in the emergency department and in the ICU, but we've had to hold beds that we would have had open on the unit. So both those areas have really been critically impacted by staffing shortages, both you know, inability to hire permanent positions, inability to bring in registry staff. Just, you know, it's really tough. And then when you have those factors combined with more people going out on leaves, more people calling in sick, more people being held out because they've been exposed to COVID or potentially exposed to COVID, all of those things really add up to a very challenging staffing situation. I mean, the thing that is so really remarkable to me, I know that our situation here at Zsfg and in the city in general is not anywhere near as bad as it is in other parts of the country. And you know, my heart goes out to places that, you know, literally have to shut down their hospitals in some cases because they can't get enough staff. So it's been hard for us, and you know, we're working out of it as the pandemic dynamics are changing.
Thank you. I'm looking at the salary variance chart, and I know it's got a lot of colors and everything, but I'm trying to figure out, is it that the year-to-date variance without COVID is 1.1 million? That's the green line? Or...
Yeah, I'm gonna let, this is a confusing chart, I agree. I'm gonna let Jennifer speak to this. I think she's the best person to walk you through the details.
Okay, we've added more detail, but now it's a little confusing to me anyway.
Hi, Dr. Chow and Commissioner Green. Good to see both of you today. I am pulling up the chart as we speak. I'm scrolling through just so I can get a peek at the right page that you're on, but I believe what you're seeing is you're seeing the year-to-date variance and how we've been running over budget all year. And then when you look at the year end and you see that we've offset for COVID and what we've claimed against PRF, provider relief funds, and what we've been able to claim as FEMA eligible. So we start offsetting everything for what we're seeing in terms of that, and that's where we start to see the reduction in the salary variance. Does that help explain?
So I guess PP variance with COVID. What is PP then?
Pay period. So we look at our payroll on a pay period basis and see how we're doing relative. That helps us compare it against the census that we saw in that pay period and volume adjust and make sure that we understand any staffing anomalies that we're seeing.
Oh, okay. I got that. I guess that was maybe the big problem in trying to figure out what PP was. And so then the year to date with COVID is like 2.6 negative. Is that correct? And then without COVID, it is 1.1. Is that correct?
Yes. So the orange line is what you're seeing, which is with COVID, and then we've got year-to-date variance without COVID is the green line, and then the pay period, each pay period is the blue.
Okay. So the new one that's a little, not new, but is a little confusing was that we're doing a pay period variance. Okay. Got you. Commissioner Green, were you confused or am I the only one confused? But I think we're fine now.
I was also confused. If you're confused, there's no way I'm not going to be confused.
No, the thing that threw me off is the pay period variance. Okay, so got it now, and that is fine. Thank you. Okay, if we have no further comments, we thank the Chief Executive Officer for their work and for submitting also the Emergency Department update, which is always interesting and does help us reflect or help us understand how they are challenged. And I'm trying to figure out how, is this sent out by email to the staff then, or do they pick up a copy?
All. It's sent out by email to the emergency department. It's sent out to all of them. It's posted in various places around the department. Whatever we can do to make it accessible to them.
Yeah. And has that been useful in terms of assisting? And I know there was a discussion, right, like last year about, the morale and all there. So I'm just wondering, is this, really bringing people even for, better to be a team?
I mean, I think so. Terry can comment. I also think, communication generally around the hospital is something that people have commended us for. Better communication during the pandemic has been a real learning for us, understanding how it helps with staff experience. And we know we can do better. As part of our staff Better Place to Work Strategic A3, we have a communication subgroup that Brant Andrew is chairing, and he has an active group right now looking at communication, really drilling in on how we can do it better and make sure that we're reaching everybody in the hospital. So we know it's really important. I think this newsletter has been great for the team in the ED, and there's probably things we can do better with respect to communication that we're working on.
Good. Terry, did you have anything to add?
Yeah, no, I think that Susan's absolutely right. We try to get this to everyone. I think that morale is not going to be remedied by a newsletter when we see what's going around nationally and the short staffing and staff leaving. And I think people are feeling that right now. I think that there are nurses and techs in the department who, don't understand why some people might be vaccinated and not, and they're getting tired of the pandemic, which again is a national trend in all emergency departments. So having the newsletter acknowledging what's going on and trying to address the different aspects of what the ED could want to help boost that morale is something that we strive to do every day. And so I think we've got some work nationally and in healthcare to help all of our frontline workers reconcile what's going on with the pandemic and the residual effects that it's done to people within their jobs.
Thank you. Thank you. Great. I think if we have no other comments, if anybody wishes to comment from the committee. If not, then let's move on to the next item.
Sure. Item 9 is the Zsfg hiring and vacancy report.
Thank you, Mark. Good afternoon, commissioners. I do have good news to report this month. The overall vacancy rate did decrease to 8.52%, and the RN vacancy rate is down to 4%. And as I've noted in the report, we had a very successful onboarding event on October 2nd and 3rd. We had 44 candidates come through. 41 of those were nurses. 25 of those started at Zsfg on 10/16. The rest will be onboarded. They just didn't complete their clearances, and we'll be onboarding them. The next event or next NEO is next week. We are onboarding 27 P103s this month and in early November. And we're also planning on having more onboarding expedited events in the future because this was very successful. It took a lot of work from a lot of people, but it was a successful event. And I also just want to highlight some non-RN hires. We did have several manager positions that we were onboarding, including the health information system manager, radiology business manager, pharmacy director, as well as we had a morgue attendant, 5 medical eval assistants, and 8 hospital eligibility supervisors. Are there any questions?
Is there any public comment, Mark?
Person online, if you'd like to make comment on item 9, please press *3. No hand, commissioners.
Okay. Commissioner Green.
Yeah, well, this was so encouraging, and congratulations for your recruitment efforts. It's wonderful. I was curious to know if there were any kind of trends in where the nurses in particular came from. In other words, we talked on and off about when you initiate the new grad programs and so forth, but are these nurses people that are working at other institutions? Are they people that are coming from non-hospital based settings? Was there any particular like secret sauce, or if you were going to recruit in Indeed, where would you send your recruitment materials? Anything at all?
I don't think there's any secret ingredient there. These are folks that had applied with us before, and so there was no specific recruitment effort on these folks. It was really just getting them selected by the managers and onboarded quickly. So I don't think there's a magic place we found any of them. Some were working at other hospitals. Some had just moved here. Some were P103s that wanted to become a permanent 2320. And then a lot of these nurses were P103. So they already may have another job where we're bringing them on to pick up extra shifts, which is helpful as well. So it was a mix, but still very successful event. So we're really happy about that.
Yeah, congratulations.
Thank you.
Is there any, we're of course in need of personnel, so that is so important, but several years ago, there was the continued outreach to try to achieve some racial equity. Was that also in the mix here? In terms of the people who then accepted our opportunities?
So we always have a recruiter working on RN recruitments, and she does reach out to a lot of different organizations to improve the diversity of our candidate pool. And so that's what we do on an ongoing basis. That hasn't stopped, and we're still reaching out to different colleges, organizations to try to get more diverse candidates. So that is ongoing, and not just for nurses. We do that for other classifications as well.
How successful have we been?
We would have to run some reports on that. I know that I know that we are working with our equity team and with our new merit manager. Now we do have a new merit manager to work on looking at certain classifications where we may have diversity gaps, where we might have improved. So I just don't have that data today to say if we've improved and how much we have improved, but that is something that we're looking on as part of our equity review plan.
Dr. Chow, this is Terry. One of the things that I'm looking at with our diversity with our schools, we're looking at the different schools that we're working with. And one of the schools that we're working with for the LPTs, for the BERT program, Gurnik Academy, just had a class come in from Nigeria. And so we are very honored to have 22 students in our psychiatric areas studying as students doing their clinical rotations. And our recruiters that work in Carrie Shop are going with our some of our nurses to help them onboard and see if they want to apply for jobs. So we are really looking at our schools to provide us with the diversity. And in this case, Gurnik Academy has been able to do that, which is really quite nice.
Okay, well, thank you very much, and we'll look forward to a report when it appears to be appropriate.
Shall we move on to the next item, Commissioner?
Yes, please.
Sure. Item 10 is the medical staff report.
Hello, Commissioners. It's my pleasure to present the medical staff report today. So the first item is for your information, and this is the clinical documentation integrity update that was presented by Erin Harries, who is the director and physician advisor for the clinical documentation integrity program. And Dr. Green had two questions about the report, which actually I think are, in answering those questions, hopefully will summarize some of the important information in the report. So Dr. Green, I think you wanted to know how the CDI program was doing so well and have managed to improve the case mix index so effectively. And so I reached out to Dr. Harries, and he highlighted that the CDI team had been conducting educational sessions with each major service line multiple times, not only to educate the faculty, but also to build respect and trust. The nurse reviewers who send the CDI queries to the providers have worked really hard to send a high number of queries per each nurse reviewer. And they've really targeted those queries to maximize impact on case mix index and financial recovery. And then he also highlighted the experience and leadership of Tammy Higgison, who is the CDI and coding director for Health Information Services. And they're really hoping that they will see even more improvement in CMI and financial reimbursement with some targeted improvements in EPIC functionality and also increased staffing of the CDI nurse reviewers in the coming year. So I think they're pretty excited about where the program is going. And then I think the other question, which I alluded to earlier, but perhaps not in the correct context, I think in terms of CDI, you were wondering when patients have both Medi-Cal and Medicare, how they are classified with respect to the reviews, targeting the queries and also the case mix index. Tammy graciously let us know that the reviews are based on the primary payer, regardless of dual coverage, that's really going to be the main driver of the CMI weight for the encounter. And then in terms of where they are focusing, historically, they really only had the bandwidth to look at Medicare patients, and that was mostly single eligible Medicare patients who make up about 30% of the total patients who are seen now. And really, they only were able to look at about 70 to 80% of that group. But now with an expanded team, they're reviewing almost 100% of admissions, although they are prioritizing in terms of provider queries, Medicare and commercial payers, because that tends to be most important for both quality metrics and financial metrics. So I'll stop there and see if there are questions about the CDI report before I go on.
Commissioner Green, did that answer your question in regards to CDI?
Yes, thank you. And it's a great accomplishment, really. I'm mightily impressed.
Yes. The presentation at MEC was very well received. Everyone was very impressed with the work that's being done. And I think our medical staff have, responded well to the queries. The team has really made an effort to make them as clear and easy as possible to respond to.
Great.
Is the CDI work related to the attending physician or to also the resident staff?
Yeah, the queries are directed to the attending physician.
Okay, great. Okay, please proceed.
Okay, thank you. So then moving on to the items for potential action, you have two reports with rules and regulations, both anesthesia and orthopedic surgery. And I believe you received copies of those. So happy to see if there are any questions about those. And then we have a one standardized procedure from the Rape Treatment Center and Child Adolescent Sexual Abuse Center, or RTC CASARC, their standardized procedure protocol 6, specifically on sexual assault forensic services. And this is a new protocol for them, but it's actually a piece of their very extensive standardized procedures that have been revised, that have been presented previously. And then we have a few revised privileges to review today. So you'll see that family and community medicine has 3 privileges that they're adding, perinatal privileges. That are done concurrently with the OBGYN department. And they are reviewed by the OBGYN department, and OBGYN needs to approve the FCM providers who wish to apply for that, and make sure that OBGYN, has the bandwidth to oversee that. So I think that was a really nice interdepartmental process. And then there are some really minor revisions to the surgery privilege list where the laparoscopic gastrojejunostomy, the open or laparoscopic gastrostomy was updated so that it reflects that it could be a gastrostomy or jejunostomy. And then a special privilege was added, the laparoscopic Heller-myotomy. So I will stop there and see what questions you have.
You actually skipped the orthopedic surgery report in your in the MEC, which of course was and continues to be impressive. I mean, the orthopedic department. And I just had a question on that, which was on page 3, where under action items, there was a comment that the action items under the driver for quality safety on surgical joint infections was education, sobriety, and multiple pre-OR visits. So I wasn't quite sure what sobriety meant in this context.
So I am not 100% sure But I think that these relate to patient factors. So I think they perhaps are focusing on patient education, perhaps patient abstinence, and trying to have multiple pre-OR visits to make that a success.
Ah, okay, that makes a lot of sense. All right. I didn't see exactly how otherwise we were going to impose sobriety as a safety driver for our staff, but not that they shouldn't be, of course.
Of course, no, and apologies for missing the orthopedic report. It was a very nicely presented at MEC, and people were very appreciative of Dr. McLeod's comprehensive presentation. So thanks for pointing that out.
No, thank you. Commissioner Green, any questions, especially with your knowledge on the perinatal or cesarean sections or privileges or anything like that?
But given how low the cesarean rate is there, I think it'll be hard to proctor 50 of them, which is a good thing in a way. I mean, I suspect that the family practice folks may not meet those criteria as time goes on, just because of the, it's great that there may not be enough cesareans for them to meet the stipulation. One question I had, and I'm if I'm in the wrong section and it was part of PIPS, I apologize, but we're very focused on in an anesthesia on timeout and so forth. But do you have any protocols for true trauma emergencies where you're whisking someone down, you don't even know what surgery you're going to need to do? I was just curious, since it is a trauma center, whether there are any either different rules, relaxations of rules, or standards that are set forth in major trauma situations where you can't, do all of the pre-op specifications that are indicated in some of the delineated steps here.
Hey, thanks for asking. I think Luke John has graciously come up, and I'm hopeful that he will be able to answer that for you.
Yeah, no, it's a great question, Commissioner Green. As much as we can, we try to adhere to our timeouts or our surgical pauses before each case, even in the cases of level 1 traumas or our 901s and 900s that go down to our room 1. We still do our timeouts in those cases as much as we can, really adhering to a standardized checklist that we follow.
So if you don't know what you're going to go in and do, because there's a lot in here about permits and so forth, and you just have no idea what you're going to find in there, what you might have to repair or remove or whatever.
I think they do as best they can, just like they do on the consent form, although in this case it's probably an emergent consent, but they try to do their best to sort of outline what they think they may do when they're doing the timeout. So, in many cases, they may not even know the identity of the individual. And so they'll still read their wristband. They'll come in as a trauma, the medical record number assigned to them. And then they'll outline very briefly what they think they may be doing. And then also anesthesia may briefly outline their plan as well, too, knowing that it potentially could change just given the nature of the situation.
I'm just curious, is there anything, if the document is obtainable medical legally, is there any thought to having something written vis-a-vis specifically trauma where you're going to do your best, but you'd hate to have somebody come back and say, well, you didn't mark my leg, never mind, I was unconscious. In other words, are there any standards that need to be set that kind of recognize the limitations in an incredibly emergent situation? We run into that with deliveries a lot, where you just have to throw on forceps and there's just no other choice, or do a crash section. And sometimes you have to not check every box, and it's comforting to have some standard that's a step down for we can't do every single thing that's listed here.
Right. I think that's a great question. I would probably have to sort of research that with our regulatory colleagues to see what latitude is given, especially under emergent situations. I think there's a little bit of breadth that's given to that, but I think, We err more on the side of trying to at least verbally state everything that we potentially can do or might need to do in those cases. But I can get back to you after I talk to regulatory and to our trauma surgeons as well in terms of their thoughts on it.
Great, well, thank you. I don't want to make a big deal out of it, but it's in a way kind of protects the provider a bit to know that there are standards you meet without every single one of these things done.
No, absolutely.
And as you are very aware, Dr. Green, the anesthesia consent also has to designate that it is an emergency. And, you know, if you do your best for evaluating how sick the patient is, and then you add an E to the end of it. And that designates that it is in fact a true emergency.
Thanks.
Yeah, thank you. I'm sure that you could check with legal counsel also. I mean, obviously, all the rules are probably not applicable in true emergencies, and but a statement might be helpful for clinicians as they're reading to understand that, but that shouldn't be taken to be a open door for them, of course. I'm wondering then, Mark, have we asked for comment on the medical staff report yet?
Yes, yes. So all you all have to do now is to consider a vote to approve.
Okay, so I'm looking, and I forgot to actually bring this up, but the orthopedic surgery rules and regulations, is that before us too?
It is, yes, thank you.
Okay, and so on page 42, it still refers in the new text to LCR. So is that correct, that we still have a formal designation of LCR in the clinics, or should that be EPIC?
It should not be it should not be LCR. It should be EPIC. If you would consider approving it with that update, I will ask our orthopedic surgery chief to make sure that update happens.
Okay, that's fine. All right. So let's see. We've got a number of things here. So let's take the clinical services rules and regulations first. If we can have a motion, and I'll accept a motion for the rules and regulation approval for both of the departments.
Move to approve.
And I would second that, and therefore we can move on to the credentials committee sections that have provided to us changes in the standardized procedures in the privilege list as outlined, and Mark will make sure that we write these all down correctly, and revised surgery privilege list. We can take them all together unless you wish to separate out any of the privileges.
Move to approve.
Okay, so we're going to move to approve all the recommendations of the credentials committee for those changes, and I will second it. And we have therefore approved all of the changes. Thank you.
Thank you, Dr. Winston. Item 11 is other business.
Okay, does anybody have any other business to present to us? And is there any public comment on other business?
First on the line, if you'd like to make a comment on item 11, please press *3. Raise your hand. No hand, commissioners, or everybody. And then item 12 is public comment. Person on the line, if you'd like to make general public comment, commenting on anything that's not on the agenda, please press *3 to raise your hand. No hands, Commissioner. So we can now go to consideration for closed session.
Okay, so a motion is in order for consideration of a closed session.
So moved.
And I will second that. So we will then go into closed session.
Please give me 30 seconds to move this over. All right, we're back into open session. And now I encourage you to consider a motion to disclose or not disclose discussions in closed session.
Move not to disclose.
Oh, Commissioner Chow, everyone's always muted when you come back in.
Yeah, I know.
There we
Okay.
go.
And I would second. So we therefore will not disclose the discussions in closed session.
Great. And now consideration for adjournment.
Move to adjourn.
And I would second that. So want to thank everybody for all the work that they've done, for, I think, another good meeting in terms of the display of the quality of work that we are all doing here. And thank you, and we are adjourned.
Take care,
Thank you.
everyone.